A cesarean section is essentially a surgical rescue mission. It's the procedure we use to deliver puppies or kittens when natural birth has stalled or become unsafe. We generally categorize these into two buckets: elective, which are planned ahead of time, often for specific at-risk breeds, and emergency, which happen when the mother or babies are in immediate distress during active labor. It's also worth noting the anatomy involved. Unlike humans, dogs and cats have long uterine horns, with the babies spaced out individually along the length, like peas in a pod. This unique structure changes the mechanics of natural birth and dictates exactly how the surgeon approaches the uterus to safely extract every puppy or kitten. Elective C-sections are all about prediction. We schedule these when we know the risk of natural birth, dystocia, is simply too high to gamble on. The classic example is our brachycephalic breeds, English bulldogs, Frenchies, and pugs. Their anatomy presents a double whammy. The dams often have unnaturally narrow pelvises, while the puppies have massive heads and broad shoulders. It is effectively trying to fit a square peg into a round hole. We also plan surgery for single pup syndrome. When there is only one fetus, it often fails to produce enough cortisol to trigger natural labor. Worse, because it has no competition for nutrients, that single puppy can grow incredibly large, making a natural exit impossible. Other common reasons to book surgery in advance include a maternal history of dystocia, previous pelvic fractures that have narrowed the birth canal, or extremely large litters. In those massive litters, we often predict uterine fatigue, where the uterine muscle simply wears out before all the puppies can be delivered. Finally, for high-value breeding programs, an elective procedure often provides the safest, most controlled outcome for both the dam and the neonates.
The emergency C-section is a race against time. We move to surgery when dystocia, difficult birth, threatens the life of the dam or the litter. As clinicians, if we see strong, visible contractions for more than 60 minutes without a baby appearing, or weak, infrequent contractions lasting more than 2 to 3 hours without progress, we do a C-section. Also, if more than 2 to 3 hours pass between the delivery of neonates. In dogs, green or black vulvar discharge before the first puppy is born is a major red flag. It means the placenta has separated, and that puppy is losing its oxygen supply. Profuse bleeding is also an immediate surgical trigger. If the dam is showing signs of exhaustion, shock, or metabolic crises like hypocalcemia, obstructive dystocia, she cannot finish whelping naturally, need a C-section.
The preoperative assessment relies heavily on a targeted history and a quick but thorough physical exam. Ultrasound is our fetal monitor. It tells us about viability. We are looking strictly at heart rates here. A happy, healthy fetus should have a heart rate between 180 and 220 beats per minute. If that drops below 150 BPM, we have fetal distress. If we see rates below 130 BPM, that is a critical emergency. Those neonates are dying, and immediate delivery is required. We use X-rays to count the number of fetuses, so we know exactly how many we need to extract. They also show us the fetal presentation. Are they coming headfirst or breech? And allow us to evaluate the size of the fetuses relative to the maternal pelvis, confirming if a natural birth is even mechanically possible.
Once the surgeon hands off the neonate, the clock starts ticking. The resuscitation team needs to move fast, and we follow a strict protocol. The ABC plus T of neonates. A is for airway. The moment that puppy or kitten lands in your hands, the first step is to clear the airway. We need to strip away the fetal membranes immediately. Use a bulb syringe to gently suction the mouth and nose. Gravity can help here. Hold the neonate head down slightly to let fluid drain, but never swing a puppy. That old-school technique can cause severe brain trauma. B is for breathing. Next, we need to trigger the first breath. We do this through aggressive tactile stimulation. Rub the neonate vigorously with a warm, dry towel. This mimics the mother's licking. If they aren't breathing well, provide flow by oxygen. If they are apneic, you may need to provide gentle positive pressure ventilation, or PPV, with a tight-fitting mask. C is for circulation. While you are rubbing, assess the heartbeat. You can feel it right behind the elbow on the left side. If the heart rate is slow, or bradycardia, your best treatment is often more stimulation and oxygen to drive that heart rate up. T is for temperature. Finally, and perhaps most importantly, T is for temperature. Neonates cannot regulate their own body heat. Hypothermia leads to bradycardia and ileus, or gut stasis. You must dry them immediately and place them in a pre-warmed incubator or on a safe heat source. Do not feed a cold neonate. Post-resuscitation care. Once they are pink and screaming, the job isn't quite done. Dip the umbilical cords in chlorhexidine or dilute iodine to prevent infection. Weigh every single neonate to establish a baseline. This is vital for monitoring fading puppy syndrome later. Finally, get them back to mom as soon as she is recovering to ensure they latch and get that critical colostrum within the first 1 to 2 hours for antibody transfer.
Now that the neonates are stabilized, our focus shifts back to the mother. Recovery here is a dual challenge. She needs to heal from major abdominal surgery while immediately meeting the metabolic demands of lactation. Pain control is not optional. Pain inhibits oxytocin release, which disrupts milk letdown and maternal bonding. However, we have to be mindful of drug transfer through milk. Opioids like buprenorphine or methadone are the cornerstone here. They are effective and generally safe for nursing neonates. NSAIDs are incredibly useful for inflammation, but should be used with caution. Ensure the dam is hemodynamically stable and hydrated before the first dose to protect renal perfusion. This is also why those local blocks we did in surgery are so valuable. They reduce the need for systemic drugs in those critical first few hours. In the recovery ward, we are monitoring the standard vitals, temperature, heart rate, and respiratory rate, but we are also watching her maternal behavior. Is she accepting the neonates, or is she aggressive or indifferent due to pain or stress? We also need to monitor lochia. This is the normal postpartum vaginal discharge. It should be reddish-brown or green-black initially, but non-odorous. If it becomes fetid or purulent, we have a problem. Before discharge and in your client education, you must warn about the big 3 complications. Metritis, an infection of the uterus, usually presenting with fever, lethargy, and foul-smelling discharge. Mastitis, look for hot, painful, firm mammary glands. Hypocalcemia or eclampsia, this is life-threatening. It often starts with subtle signs like facial rubbing or stiffness and progresses to muscle tremors and seizures. This is most common in small breed dogs with large litters. Finally, keep an eye on the incision site. Puppies have sharp claws, and they will be kneading right next to that fresh surgical wound. Clients need to check daily for redness, swelling, or dehiscence.